Welcome, everyone, to the Friends of NPACE Podcast. I'm Teri Schmidt. I'm the NPACE Executive Director, and I'm also a practicing family nurse practitioner. And I'm super excited to be here today with a very special guest that we have on a topic that we've actually not covered much and is really important to what I think happens in the primary care space. Today, we're talking to physical therapist Tami Recesso. She has a doctorate in physical therapy, and we're going to talk about how primary care providers can better assess and direct their own patients and some pearls about physical therapy because it's an area I don't know much about. So Tami is a physical therapist licensed in New Hampshire and Massachusetts. She has built a well-respected physical therapy private practice. She's done that more than once. She and her staff provide services to other healthcare providers, and other healthcare providers lean on them in their most complex clients who have physical and musculoskeletal needs and are unsuccessful in other ways that they're treated. She has a commitment and a passion to manual therapy, spine care, and having over 28 years of clinical experience. She's developed an innate skill of quickly deducing the culprit of pain and successfully resolving it permanently and efficiently, which is something we would love to give our patients. She's built an online medical platform called doctami.com that offers assessment tree knowledge. And I'm going to say this wrong, but you're raising the bar of physical therapy provider autonomy, efficiency, expertise, and outcomes. Did I get that all right, Tami?
Yes, ma'am. Thank you.
Thank you for being here with us. So tell us a little bit about how you got into physical therapy and specifically how you got into manual therapy.
Thank you, Teri. So years ago, I was working in a hospital and I knew I wanted to get into medicine. And there was actually a shortage of physical therapist assistants. And within the hospital, there was an ad for an accelerated 13-month program funded by the federal government to earn your physical therapist assistant degree. And I applied. There were about 22 of us that applied. About 12 of us were accepted, and we were on the fast track, nights and weekends, along with working to learn physical therapy and sit for our boards, for half of the boards for the physical therapist assistant. Once I did that, I knew I was in the right place because I just loved it. I really enjoyed learning all about the anatomy, physiology, how the body works. And I loved that I was helping people. So I decided to continue on for my bachelor's, master's, and doctorate over the years, and while still working in clinical practice.
Nice. That's impressive. I love that you started as a physical therapy assistant. So many nurse practitioners, of course, started as nurse assistants, and then they got associates or diploma degrees, and they just kind of kept going to school to learn. Your journey's been interesting because you're a business owner, right? What got you into that aspect of physical therapy?
Well, that was really the driving force. Was as a PT assistant, I needed to work under the license of a licensed physical therapist, and I wanted more autonomy. I saw myself calling my own shots and really just being much more independent. So that's why I continued my journey so that I could learn more, so I could be on the front line of evaluating and treating and prescribing plans of care.
That's a really great point. That's why many of us end up in provider areas. Physical therapy is not something that I'm very familiar with. So I think I want to start with the most common. What are the most common things you see and that you get referred to you? And I'll have a million questions from there.
Great. So physical therapy is quite vast. Lots of people go into specialties, just like doctors and surgeons and pediatricians and dentists and oral surgeons, so on and so forth. So the category of physical therapy that I love is manual therapy, outpatient orthopedics, and private practice. I love private practice because it's owned by a physical therapist, so their heart is in it versus just being a business. Yes, it's great to make money, and that's not the number one reason why I'm in the business that I'm in. I'm in it to help people And I love the variety of just meeting so many different people, and not every single person has a unique representation, and there's always something different to figure out. However, over the years, I've definitely noticed some patterns. What I see often in my practice is back pain and sciatica related symptoms. And I've attended tons of continuing ed seminars around manual therapy, which is my love as well. Not all outpatient orthopedic therapists go into manual therapy. Some are mainly exercise based, some are sports related, some are on the field of play with athletic trainers. For me, it's more of an outpatient practice, almost like a doctor's office. And I put my hands on every single person that comes in. I assess and palpate. I know many techniques in my toolbox that I pull out. And just watching the pattern over the years and watching the red flags that show up or the yellow flags that show up, I've learned how to navigate, just how to really get to the bottom of what's driving this pain. Is it really plantar fasciitis? Is it really medial meniscus? Is it really, the knee or the foot or the ankle, or is it coming from the back? Which lots of times it is.
Yes, the knee bone's connected to the thigh bone, right? I think
100%.
I love that you said back pain, because I'm getting older and I have so much of that. Before we go down the back pain rabbit hole, what is manual therapy? What is it and what is it not? So if we're referring someone, if I have someone with back pain and I want them to be seen, what advantage will it get me to see someone that has manual therapy expertise?
Well, manual therapy is really, looking at the area and palpating the actual area versus just guessing or assuming, which could get us into a lot of trouble oftentimes, right? Not everything is exercise remedied. Not everything is pain med remedied. We all know that. Not everything is injection based remedied. So, what is manual therapy? It's actually applying your hands on the person and delivering different types of techniques, such as osteopathic techniques, such as strain counter strain, which is one of my greatest go-tos. It only takes 90 seconds. It's very efficient. It creates a neurological change in the muscle. It helps correct postural alignment, which a lot of times is the problem. And there are other techniques in manual therapy, like craniosacral therapy, which is working on the rhythm of the body with the brain and the spinal cord, which is your body's control center. And then there's myofascial release, which would sort of loosen up any restrictions along the fascia in your body, which are similar to 5 layers of saran wrap that envelop all around your organs and your muscles and your tissue and your nerves and your blood vessels. And if there's an injury or scar tissue there, it can become a major problem.
I love this. So when people come to see you, you're going to have an assessment, you're going to do a complete assessment, but then you're going to put your hands on them. You'll have an idea of what's going on, and you're going to do a set of prescriptive things that you know to do that will help those areas. How long can someone plan to spend with you? How many times do you see them a week? Let's say they have low back pain and sciatica.
Mm-hmm.
How do you start with that patient?
So our first visit is always an hour.
Okay.
And we spend the first half hour really evaluating and taking a very thorough history, because a lot of the gems are in the history, not finding out what the person did last week, but finding out what the person did even 20 years ago, and not getting into an hour and a half of an interview, just being really concise and direct and to the point around, okay, tell me this, tell me that, and really leading the patient in terms of helping us understand what their walk has been like overall. And then the second half of the treatment would be hands-on. Once I assess and see a postural asymmetry, muscle weakness, a nerve sensation issue, once I hear in the interview specific complaints that lead me towards nerve related or sciatica versus a typical musculoskeletal injury, then I know exactly how to treat, and I just get right to it, correct a lot of the imbalances. And typically a patient would find relief sometimes the first day, not 100% all the time, but oftentimes I hear, wow, I've had this pain for 25 years and now it's gone. I can't believe this. And yeah, maybe in a day or two, it might come back a little, but it may not come back as strong as it was the first day. So to answer your question around how often would I see that person, it would definitely be a couple times a week for 4 to 6 weeks to start. Then we reassess. We reassess functional outcomes. We reassess their goals. We reassess how long, objectively they can sit, stand, walk, get back to their daily life. And we also have measuring tools where we measure their joints. We have muscle testing capabilities where we test their muscle strength. And what I find oftentimes is once we can decrease the pressure on the nerve and the path that the nerve travels, a lot of the activation and function of that muscle comes back and a lot of the pain goes away.
Nice. So they get relief instantly. If it's a nerve track and it's inflamed or there's been pressure, you follow up with them at least a couple of times, right? To make sure that you're getting progress. Do people come back for tune-ups or come preemptively? Sometimes if they know, I'm going to go do this thing and this is going to flare.
Well, we try not to get into maintenance because legally we're not supposed to with
Okay.
Medicare guidelines and whatnot. We are supposed to really have medical necessity. So what I tell my patients all the time is if you do this one exercise for the rest of your life, if this is applicable to them, which 99.9% of the time it is, you won't need to see me again for the same diagnosis. And yes, you might flare up, but you're going to know what to do. So my job is empowering patients to understand what they can do for themselves versus letting the pain control them. And it's not to get them to repeat and come back to me for years. Have I had repeat clients? Absolutely. Have I for the same reason? Yes. Why? Lots of times they're misbehaving. They know that they're doing something they're not supposed to do, and or they're not doing their exercises. So on, or there's another injury, or it's, just something else, or it's a totally different body part, which is great because that's just something clean and separate. It's not typically related to why they came in the first place.
Yeah. No, I love that. They had so much success, right? The first time, and they're like, that really worked. I'm going to go back and see her again. It's so great. I love how you said you got into people's, not what's happened in the last few weeks. We always ask that as clinicians. Have you had an injury? Did you do this thing? I remember one time I had a patient who she'd had sciatica and low back pain for years, and everybody kind of chalked it off, and she was retired. So I asked, what did you do before you retired? She came in to see me one day, and she had been a bailiff and worn a duty belt for years, a heavy 25-pound, all her stuff in it. And no one had ever, she goes, you're the first person that ever asked what I did. And it was so much insight into what had been happening to her hips and her low back, the previous 2 decades before she came into my office. Very interesting.
It's so important. It's so important because they were not in a bubble and their whole life, right? They weren't in a bubble, and they've had different adventures in life, right? Different, even something as simple as a quick ankle sprain up that kinetic chain that could throw off the sciatic nerve, piriformis, the hips, the neck. It's amazing how connected we really are, and the slightest thing that somebody would just brush off. Oh yeah, well, I was in a head-on collision, but that was when I was 18. I'm just in pain now because I'm getting old. And I don't buy that. I don't buy the I'm getting old or I'm overweight. Yes, it plays a factor 100%. And there are other ways across the room in terms of addressing what's going on and really getting to the bottom line.
I appreciate that because that's going to lead into the next question. US in general as a population, you said you've seen a lot of back issues, and we know how common that is in primary care. What's something, just if we're going to pass off information to everyone, to every patient about protecting their spine or taking care of their spine, what is one thing we could be advising patients that would help in the long run to either prevent or minimize back pain?
So my best friend is the piriformis stretch. And on my platform, doctami.com, and on YouTube and on the web, I have videos of myself performing the piriformis stretch. I also have like 180 videos of all different types of exercises per body part. And piriformis stretch is your best friend. I tell everyone to perform that for 30 seconds, 3 times each hip, pain-free. Because if it hurts, they really do need to back off because they could really hurt themselves.
Okay.
But pain-free stretching and exercise is number one key. The minute you experience pain, that's your body's way of telling you that you're not ready for that just yet. To back off, please. And if you honor me, I'll honor you. And it will definitely allow you to go further if you respect your body's limits and where you are at the moment. So 30-second hold, doing that a couple times a day, trying that even before you get out of bed. And if that alleviates your leg symptoms or your foot symptoms, like plantar fasciitis or medial meniscus or that knee that buckles, like these are a lot of things I hear. And lots of times, where somebody is sent here with a prescription that says these diagnoses, we always look above and below the joint and consider what provides the function, which is the central nervous system and the nerves. So thinking about that whole chain,
Mm-hmm.
and if you can alleviate the pain with the piriformis stretch, you're on the right track of some of these symptoms really could be coming from the glute and the low back.
Okay. I'm writing all this down.
Great.
People who listen know I'm like frantically taking notes to go back. So, all right. I really like that. You hit on something there. So when we send you patients, we'll talk about barriers and cost and things that are affecting the low back in just a second. But so I'm going to send you a patient, right? And I'm going to write a referral, a prescription, please assess them. What do you need from me as the primary care clinician to see that patient? What helps you the most? Or is it just meeting with the patient if I just send them to you?
Well, what helps me the most is for you to screen out any medical red flags that could be related, right? Like a underlying cancer or broken bone or something like that, if you really feel like there was some type of traumatic risk that occurred. So just making sure that they're medically stable, because we're not doctors per se, right? We're physical medicine experts in terms of physical therapy, right? Under our licensure. So making sure that that they're clear, they're medically clear to come in for PT, and they're medically clear to perform different types of exercise. Safety first.
Nope, I like that a lot. Do you find patients are reluctant to come and see you?
I find patients aren't aware of what we do often, which is why my mission is to raise the bar of physical therapy, autonomy, independence, and just ability with the tools that I can provide, the quick, easy methods. And so I feel like they don't understand completely what we do, what we can offer. We do a full musculoskeletal assessment and evaluation with range of motion, with manual muscle testing. We know a lot of special tests as well to rule out the red flags. However, of course, we always defer to the primary care. But with our doctorate, we do have direct access where we may see the patient before the primary care, depending on the insurance. So that's where our special tests come in as well. And we do need to send them to their primary care if the person isn't getting better within a certain number of days, of course, to be medically safe. So pretty much what you could send us is just an evaluate and treat. And if you had any diagnostics performed, which that's not always my go-to, unless you're really fearing that there's something that's dangerous or underlying.
Right.
Uh, yeah. So just making sure that everybody is medically clear.
Okay. Definitely, we can do that. The primary care guidelines for low back pain really don't call for any radiographic imaging until a patient's had pain longer than a certain amount of time. But I really think sometimes we miss the early physical therapy piece of that, how
Yeah.
helpful that can be in the muscle part of musculoskeletal issues, the pulling and such. And you bring up a great point with insurance because every clinician that sees patients will have a barrier somewhere with that. How much of a barrier is financial? Does insurance typically cover this? Is most insurance? What kind of issues do you see?
Well, that opens up another can of worms, because I've been in practice for a long time, almost 30 years now. And when I started, some people had zero copay. It was right before the HMO, really. And now the HMO, and whoa, now sometimes the copays are $50 a visit, sometimes they're 75, which ultimately it's almost like paying for a whole visit when you really consider the fee schedules with the insurance companies as well. Um, the insurance companies ask us to jump through quite a few hoops in order to reimburse. So we're not always likely to get paid. So on our end, from a private practice perspective, uh, it's uh, it's really challenging. It's really challenging to learn the insurance rules as they change every year in different insurance companies have different rules. So we really encourage the patients to understand their own benefits. And yes, sometimes a patient can't afford $75 twice a week or $50 twice a week.
Yeah. Yeah, and they do change, right? Every year, every January, even if they stay with the same insurance, and we have so many high deductible plans now that
Yeah,
patients are navigating. It's problematic. Yeah. I'm sorry you're dealing with the same things. And just to get credentialed with the insurance, all the paperwork and keeping up and the licensing. So it's a barrier on both sides, I think. Yeah.
absolutely. Absolutely.
I love that you have a website with all of these videos. Can't clinicians go in there and like learn and better direct themselves and have some pearls when a patient comes into the office in case they can't see you?
Yes, yes. Actually, my goal is for clinicians to receive the plan of care, so that they can do as they see fit and refer as they see fit. So it will help clinicians deduce the culprit of where this is coming from, just based on the interview and based on the form that they fill out.
Did your
The clinician will have, go ahead.
No, I was going to ask if the website has that information on it, the videos you have. Do they move you through assessment?
They do. It's there's a purchase for membership, and
Sure.
then you could have access to assessments, and or you could do an a la carte assessment or a yearly membership where you can have access to different assessments, so that if you are treating somebody, you can kind of run them through the same questions, and you'll receive a sheet of suggested diagnoses, suggested plans of care, suggested treatments, just based on my experience.
Sure. Oh, that's fantastic. I'm writing all this down. The education we didn't know we needed. What, besides the piriformis stretch, is there anything that we're doing as America? Are we sitting too much? Like, what's the thing that we could change in our everyday routine besides adding some stretching to it?
The tech neck. The tech neck, the technology, right? Like the posture. Honestly, 99.9% of people that come in, the posture is a major contributing factor for their pain, their radicular symptoms. And especially because sometimes I'll come from eye, right? We get lost in it, and we could be there for a long time in this position, and eventually our fingers are going tingling or numb, or our elbow is bothering us and we're like, oh my goodness, we need to put this down. So yes, the technology has been a blessing, and it's also been an issue in terms of pain.
I well, I think it's coming both ways. My thumb sometimes hurts from sometimes, but also I'm looking down and it's ruining my eyes and also my attention span and
Yes.
reading level. But yeah, I mean, yeah, neck and thumbs, and it's just both ways, I think, going.
Yeah.
Okay. Yeah,
I
and I
speaking of that, yeah, excuse me, speaking of that, we also teach very specific exercises for neck pain, to stretch out the neck as well.
oh, nice. I really like that. All right. So
Yeah.
this is so great. So, the big takeaways are most of it is all connected. It's somewhere in the spine. You need us as clinicians to know that you're there to send you patients, but also to rule out the major medical. Sometimes I think we're so quick just to write a prescription because it's easy in a 15-minute visit instead of going, you really should see someone who has this skill. It's worth it in the end. We're not going to be 6 weeks down the line and you still can't walk and you're still hurting and you've missed work and now you're out 2 prescriptions. In the end, the money transfer is going to be the same or less if I send you to the physical therapist.
A hundred
Uh,
percent, 100%. And what I've noticed is primary care will send to orthopedic, and then orthopedic will send to physical therapy for 2 weeks, and then see them again. So it's almost like, cutting out, if it isn't a surgical candidate, right? Sending them to physical therapy first, because lots of times that's what the orthopedics are doing anyway, because of, I think, insurance guidelines is what's been explained to me. So allowing us to have a couple of weeks without a lot of medication or any at all, because pain is our friend. And if we numb the pain, people will blow through that signal and that barrier
Mm.
and potentially hurt themselves even more.
yeah. Yeah. The push through kind of is not a good adage. We shouldn't tell people to push through their pain. Okay. We'll try not
Right.
to do that. I know we only have a little while here. I do want to cover a couple other things. You're going to speak for us in September. We're going to do it virtually, just like
Yeah.
this, and we're going to talk about back pain and how to assess for it. And we're going to do some hands-on with some of
Yes.
these skills. Oh, I'm so excited. We better tell people to dress comfortably for that because they'll all be behind their laptops doing things. That's really good. All right. Otherwise, so not looking at our tech, piriformis stretch. Is there anything else we should really be thinking about with our patients? Patients come to you and go, gosh, my primary care clinician didn't say anything about XYZ or considering this. What are we missing other than sending people?
I would say asking questions about the history, as I said before, and then asking about the amount of time they're spending on electronics. I notice when we go to the pediatrician, that question is asked often, but I don't know if I've ever been asked that as an adult. And we're all on the electronics as well. And just really documenting the posture and encouraging them to sit up taller, maybe purchase a shoulder support to wear an hour or so a day, just to bring those shoulders back,
Okay.
sitting up taller, allowing the spine and the body and the nervous system to work efficiently and effectively. Once we're slouched, it's not really effective. And it's just promoting a malalignment that can cause major issues.
Okay. How do clinicians find out whether a physical therapist does manual therapy or not? Will it be in the specialty listing for that if we go searching? So there are so many insurances out there. Sometimes I send patients themselves to go look who's in network. Will it tell them that who does manual therapy? You want someone in network who does manual therapy.
That's a great question. I'm not sure because I haven't really done a search on that. However, a lot of patients will go to my website. So
Okay.
they'll go to their insurance and see me on the list. Then they'll go to my website and we talk about what we do in terms of manual therapy. So I always encourage patients, if you are looking and you're not in this area, of course, always look at the website, find out what the philosophy is around their plan of care. You can even call and ask, do you do manual therapy? Do you put your hands on patients? And if so, what percent of the time are you doing that? And then also, if you know about some of the certifications, you can always ask, are you certified in this or are you trained in that type of procedure? So in going with private practice, oftentimes I think is key. I'm also very biased because, like I said, therapists are in it because they love it and not just to make money.
I love that. I love also that your earrings match your picture behind you. You coordinated that so well.
That's my logo.
It's so beautiful. It works really well today. We are all about encouraging private practice and entrepreneurship as well. I think it brings a different element to the table. So I love that you're doing that. People will know you, right? When you go in, they know who you are and they get to really know you as a clinician and you know them as a patient. And then when they come back for their elbow pain this time instead of their sciatica, you're already established. Excellent. So that's so great. So doctami.com, is that where everyone can find you?
Yes.
DOCTAMI. All right. Awesome.
Yes.
This is wonderful. Okay, so September virtual is the 19th and 20th here at NPACE. And I know everyone behind the scenes because I have this great production crew. You're talking about posture, and I know they're all back there like sitting up taller and doing their thing. So we're going to work on that because we all sit all day long. Tami, anything else you want to leave us with that we didn't cover today that we should think about before September when everyone joins us?
I would say teaching your clients or patients how to just perform a gentle chin tuck is key for postural alignment for the C-spine.
Okay.
So just if you notice somebody like jutting out with their chin, you want them to bring their chin back. You
Okay.
may see a double or triple chin, and that's okay. But what that does is that elongates the posterior subocciput area, which really contributes to headaches and neck pain. And the weight of our head, about 12 pounds, if it's not centered on our shoulders, it's hanging there. Everything here is becoming very tight into the jaw, etc. And everything in the back of their neck is really overstretched and weak, trying to keep the head up. So just practicing good posture and encouraging patients to perform a chin tuck is key, as long as it's pain-free.
Okay. And we do that right? We just have them pull their chin back to align their posterior around the cervical spine. Okay.
Yes. And just do it every so often. You don't have to hold it there, for too long, but just visit it so that you're encouraged to actually sit up straight and keep your head up.
Okay.
Versus hanging forward. So that's a nice tip that everybody could do.
Is there a certain amount of time they should do that? Or is there a cue? Or I feel like I should walk around with a book on top of my face. That kind of.
No, because then that's kind of forced, right? Like you want it to be natural, but maybe just a 1 to 5 seconds, pain-free, bringing it back, and then go back to your neutral, but eventually encouraging just sitting up taller and bringing that head back a little bit.
Okay. That's excellent. I love that we had hands-on during the podcast, which we'll do with people. Oh, Tami, thank you so much for being here and just sharing some of this information and sharing about your journey and how you got into physical therapy. We're so glad you did and that you're coming back to teach us. For everyone listening today, be sure to check out everything that we have at npace.org. We have all of our podcasts there. We have some more education. But in September, on the 19th and the 20th, from your own home, you can come and Tami's going to teach us more about physical therapy and how we can hone our own assessment skills with back pain and hip pain. So we're so excited she's going to be there. NPACE is an ANCC accredited provider of continuing education, and we offer in-person and virtual and on demand. So you can find us there and wherever you listen to podcasts, Apple, Spotify, YouTube, even at learn.npace.org. So everybody, thank you for being here today. Tami, thank you for being with us.
Thank you for having me.
All right. Until next time, this has been the Friends of NPACE podcast.